pylori. As you could see, 90% is present in duodenal ulcer, and more than 75% is present in gastric ulcers, okay? Other risk factors that are associated with peptic ulcer disease, you know that is caffeine, as well as spicy foods, patients that are taking NSAIDs for any other reason, patients that take steroids, and as well as family history and personality type A, like if you're very highly obsessive compulsive, which is not me. No, it's not. You are also at risk for peptic ulcer disease, okay? So basically, factors that could irritate the GI mucosa, all right? As well as, of course, alcohol use, okay? So what are the symptoms of peptic ulcer disease? Remember that in the past we used to discuss that duodenal ulcer is this patient that has burning sensation that is produced when the patient is empty stomach and when the patient eats and or when the patient takes antacids, either over the counter or H2 blockers or PPI, that relieves the symptoms. 2 hours after postprandial, which is also typical in peptic ulcer disease, since the gastric outlet is completely empty, the pain recurs. Okay, that is typical for peptic ulcer disease, which is completely opposite for gastric ulcers. Patients do have the pain, and when the patients eat, that exacerbates the pain. Okay, even though it's also associated with relief with antacids and H2 blockers, etc. So far, so good? That's easy. All right? So how do you diagnose the disease? Well, since, and again, it's a given, I don't have to tell you that H. pylori is the most common risk factor for peptic ulcer disease. So therefore, number one, you're going to do the first initial diagnostic test targeting H. pylori. And the treatment is also targeting H. pylori, all right? Even though it might not be stated in the question if you're referring to an exam. So therefore, how do you diagnose H. pylori? Well, the most easiest and the least invasive and the least expensive method is to do urea breath test. So basically, you will be taking a liquid, okay, that allows the bacteria to release urease, okay, and that is captured by a machine, okay. So basically, the patient will breathe through that tubing, and that will capture the urease that releases the bacteria, okay? So, meanwhile, I mean, many practitioners have this in the office, so they can do it right away, but many others will put the patient on prophylactic medication before the test, even though it can produce a false negative result, okay? But again, why sometimes we don't even have to diagnose H. pylori? Because it's highly prevalent as a risk factor for this disease. Do you understand? Okay. So, now, just because you have been positive for H. pylori, and listen to this, because it's clinical guideline as well as a question, having positive H. pylori without symptoms does not require treatment. Because there's many cultural populations that they have in their normal flora H. pylori. So Hispanic population highly prevalent with H. pylori. If you do not have symptoms, the guideline says that there's no need for treatment. Okay? So if you're this eager person that just because you have a family history of H. pylori and peptic ulcer disease, you just want to do the test and see if you're positive, just because you are positive, but do not have, never develop symptoms, you do not require treatment. You understand? It's the same as an asymptomatic bacteriuria that you don't treat. Okay. But once the patient has signs and symptoms of peptic ulcer disease, deserve treatment because H. pylori have been known by research studies that produces high degree of gastric cancer. Okay? So that's the reason why we pursue and treat this bacteria.
But still, you don't treat it if there's no symptoms.
Imagine that I was positive for H. pylori and I have symptoms, right? But imagine that now my son says, well, let me see if I have it. And he goes to the PCP and the PCP does the urea breath test. Just because he might be positive as well, doesn't mean that he requires treatment. You understand?
Doesn't have symptoms.
No, no symptoms, no treatment, okay? But once the patient has symptoms of peptic ulcer disease, if you are positive for H. pylori, of course you deserve treatment. And again, as I previously stated, the guideline says that 40% of patients are never tested because the most common etiological factor is H. pylori, and therefore you would treat the same way. Now, what is required is that if you never treat and if you never diagnose a patient, if you never use any diagnostic data to test if the patient was positive for H. pylori, once the patient finishes treatment, you are required to do a urea breath test. Do you understand? To see if the patient remains positive or if you have eradicated that factor that you suspect. Okay? So, highly sensitive and specific, that's the reason why it's the initial diagnostic test. Okay? What is the highly relevant or highly specific diagnostic test? Of course, endoscopy is the number leading one. Okay? Because not only you go straight and you do a urea rapid urea rapid test that also diagnose the patient with H. pylori, but you will also take a biopsy. Okay? What else can you do? Well, you can measure antibiotic. I'm a little still. I'm not even supposed to be here. So my brain suffer a little bit. But for those that don't know, I had a major death episode last night. Near death.
What?
Yeah.
You wouldn't be here.
Well, late.
Yeah.
Late. So, what else can you do? Well, you can measure antibodies for H. pylori, but remember, if you have ever been exposed to H. pylori, you can even be positive for H. pylori for at least 3 years after you went through the acute episode. So just releasing antibiotic and have been positive for H. pylori only tells you that the patient has been exposed to H. pylori, but that doesn't mean necessarily that the patient is going through acute peptic ulcer disease and deserves treatment. Okay? Now, what else can you do? Well, CBC is not a relevant diagnostic evaluation. Yeah, I'm teaching through my laptop.
Okay, you mind if I come in here and try to?
Of course. So, anemia, what do you think, what type of anemia do you think these patients might tend to have? B12, pernicious. Why? What is in your stomach?
Because
Parietal cells. So any alteration of pH would also alter gastrin, alter parietal cells, and therefore the release of intrinsic factors. So these patients tend to have mostly B12 deficiency, pernicious anemia. Okay? So what are the complications of having H. pylori? Well, number one, the reason why we eradicate H. pylori is because of gastric cancer. Highly relevant. Okay? And in addition to that, having peptic ulcer disease, the mucosa would ulcerate, and patients can have hemorrhage, hematemesis, so upper GI bleeds. And in addition to that, healing after healing, inflammatory process after inflammatory process can produce scarring tissue at the level of the gastric outlet, and that can produce an obstruction either through the lower esophageal sphincter or through the pylorus. Okay? So at any level. In addition to that, it could produce gastrinoma, which is no more than when you have a hypersecretion of hydrochloric acid, that can produce a tumor. And a tumor that produces high amount of gastrin, and therefore a vicious cycle of more acidity. Okay? So this is the neoplastic condition. So Solinger-Ellison syndrome not only is associated with H. pylori, but in addition to that, it can be produced by any autoimmune condition that can also produce collagen aerosol syndrome, but this is no more than a tumor that produces high levels of gas stream, therefore hypersecretion of hydrochloric acid and ulcers as well. So, and as I said, cancer. So, recurrency. The problem is that, for example, I can give you an example of myself. I was diagnosed with H. pylori symptomatic 6 years ago. I was treated for H. pylori. All the symptoms went away. And now I was diagnosed again with H. pylori, having symptoms of Peptic ulcer disease. And I went through treatment again, and I truly believe I haven't been eradicated. So you have a high recurrency once you are diagnosed with H. pylori, okay? And to have a good compliance to treatment is highly difficult because these patients need to take either 3 or 4 type of antimicrobials 4 times a day for 2 weeks, which is, you know, difficult to comply. And that's one of the reasons for recurrency as well. Okay. So you need to know this treatment. So how do you treat the patient? Well, there is a major selection of antibiotics and proton pump inhibitors. Remember that never choose H2 blockers or antacids. Once you achieve this level of treatment, you are the highest step approach. Remember the step approach for Peptic ulcer disease? So you have to step up, never step down until the patient passes the 2 weeks, okay, of treatment. So that means that you're going to choose a combination of 2 antibiotics and a proton pump inhibitor for triple therapy. And if you choose quadruple therapy, which is highly indicated for recurrency, you're going to choose 2 antibiotics, 1 proton pump inhibitor, and 1 antimicrobial, which is not the same as an antibiotic, which is peptobismol. Okay? So, to give you some mnemonics, you can, do MOC, AOC, or MOA, which no more is, for example. M is for metronidazole, which is flagyl. O is always for omeprazole. You could choose omeprazole, pantoprazole, any proton pump inhibitor of your choice. Okay? And clarithromycin. So that is the macrolide antibiotic. Okay? If you don't want to choose the clarithromycin, which is not listed here, you can also choose tetracycline. Okay? For example, if the patient is allergic to penicillin, and in another example, the patient is allergic to penicillin and you don't want to choose penicillin, you can choose tetracycline along with clarithromycin. Okay?
Oh.
Another combination. Huh?
So
Remember, 2 antibiotics. Remember this: 2 antibiotics and a proton pump inhibitor. That's the triple therapy. Quadruple therapy: 2 antibiotics, a proton pump inhibitor, and an antimicrobial, which is peptobismol. Okay? So, AR will be amoxicillin, omeprazole, and clarithromycin. But as I said, you don't want to choose amoxicillin because I'm allergic to penicillin and I had an anaphylactic shock, so I can't have it. So you can choose tetracycline instead. Okay? And the quadruple therapy, as I said, you can choose a variety of, for example, again, try to avoid H2 blockers. Do start H2 blockers when you're doing the step down. And the step down, this is the required guideline for treatment. You do either triple therapy or quadruple therapy. Remember, try to choose quadruple therapy once the patient has tried triple therapy and has failed treatment. So in recurrences, okay? So, imagine that you start the patient on clarithromycin, omeprazole, and tetracycline, for example. Okay? Patient goes 2 weeks, 3 to 4 times a day. Okay? You look at the compliance of the patient, how busy the patient is, how the patient can manage medications. If you think the patient is only able to take 4 times a day, you're going to choose 3 times a day, for example. You're going to do, for example, amoxicillin, you can do 500 milligrams. Okay? You could do it Q8 hours, which is 3 times a day, right? And you could do omeprazole, highest dose, 40 milligrams, 1 tablet twice a day is not the regular dosage of once a day, okay? twice a day for 15 days. And you can choose clarithromycin 100 milligrams twice a day for 15 days, okay? So that is the minimum that you can do. Then you treat the patient for 2 weeks religiously, okay? No alcohol, try to avoid all the risk factors. And then the patient will stop treatment for 2 weeks more without taking anything, nothing, okay? And then after those 2 weeks, the patient will repeat a urea breath test to see if the bacteria has been eradicated. Then after that, the patient has recurrency of acid reflux, or patient has recurrency of the burning sensation or dyspepsia, which is, the nausea and difficult to digest properly certain fatty foods. You can tell the patient to continue omeprazole and then step down to H2 blockers and then step down to antacids. Do you understand so far? Yes? No? Again, triple therapy for 2 weeks at your choice, stop for 2, repeat the urea breath test. If the patient recurs symptoms after those 2 weeks, then you could do the step down approach. Okay? Now, if at any point during the 2 weeks of waiting, free of medication to do the urea breath test, the patient gets any burning sensation and any dyspepsia and decides to take omeprazole again, you should not do the urea breath test because it will give you a false negative. Because achlorhydria will provide a false negative result. But that would, it's the login.
Yeah.
Alright, thank you, bye-bye.
So look at the proton pump inhibitors that you have available. Look at the proton pump inhibitors that you have available. You can choose lansoprazole, which is Prevacid. You can choose rameprazole. You can choose pantoprazole, omeprazole, or esomeprazole. We normally tend to choose the cheapest, which is the omeprazole. Okay, Prevacid. But it's not wrong that you could do pantoprazole that we do in clinical practice in the hospitals. Okay?
Dr. Leal, will the urea breath test only be positive in the acute phase?
In the acute phase.
Okay, so that doesn't apply for the 3-year thing.
No, that's the antibodies.
That's the
That's the
antibodies.
antibody. Okay, gotcha. Okay.
Okay, that's the urea rapid test.
Okay.
Because you go specifically, you go directly to the mucosa by endoscopy and you can do another test.
Gotcha.
The patient doesn't have to breathe on a machine. Okay? Okay? Any question? What else can you do? Well, you have the choice of, for example, combination instead of bismuth, which is Pepto-Bismol, to choose misoprostol, cytotec, but remember, that basically inhibits prostaglandin and the patients can have, increases prostaglandin levels at the level of the mucosa, and that can provide, for example, if you are pregnant, to produce uterine contractions, etc. And if at any point the patient is in the how do you call when you can become pregnant? Various stages, right? So you can, if you become pregnant, that can produce all sorts of other things. Okay? So again, antacids and H2 blockers are chosen for the step-down approach. Always start with the highest step level, okay, which is your proton pump inhibitor, in combination with 2 antibiotics, and if you choose quadruple therapy, Pepto-Bismol, okay? Any other question? No? Now, this basically is for complications, okay? So for example, if you have a patient that already have gone through gastric cancer, produced by H. pylori, mistreated or non-properly diagnosed and not treated. Of course, the patients, or Soligen and Ellison syndrome, which is a gastrinoma. The patients will have, of course, gastrectomy partial or complete. And you know exactly that what could apply. The same way as if you do gastric banding or gastric bypass, that patients have hypovitaminosis as well as peripheral neuropathies and vitamin B12 deficiency. In addition, you can go straight and do vagotomy. Remember that the vagal nerve is the one that innervates the stomach. That basically inhibits the amount of hydrochloric acid that is produced by gastrin, but it would never cure H. pylori. Okay? You could do anything to decrease the amount of hydrochloric acid produced so the patients can have symptom relief, but the etiology is not eradicated by doing that. Gastroesophageal reflux disease, you know that gastroesophageal reflux disease is no more than the lower esophageal sphincter that is incompetent, that is unable to relax properly, therefore the patients would eat and would have a major acid reflux, okay? The risk factors that could be associated with that, maybe the same risk factors of peptic ulcer disease, except that this is highly forgotten, that the H. pylori has nothing to do with gastroesophageal reflux disease. Now, of course, if you have gone through high levels or a long period of peptic ulcer disease, that could damage the lower esophageal sphincter, and therefore the patients can have associated GERD, okay, or gastroesophageal reflux disease, okay? But mostly weight gain. So once your abdomen increases and pushes up on the diaphragm, that is the contracture of the lower esophageal sphincter is impeded, therefore the patients can have gastroesophageal reflux disease. Other factors that patients will take calcium channel blockers. Remember that calcium is necessary for the muscle to contract properly. So patients that take calcium channel blockers can also have lower esophageal sphincter dilated and produces GERD as well. Okay, so the major problem, you know, that we're trying to avoid is that by having chronic acid reflux into the esophagus, that produces a metaplasia, which is the precancerous condition, which is called Barrett's esophagus. Okay. All right. So what are the signs and symptoms of gastroesophageal reflux disease? Basically, the patients would have heartburn. So it's a burning sensation that the patients actually described in an awkward fashion. Sometimes the patients come in with retrosternal chest pain that is burning, highly confused with acute coronary syndrome. Okay. Some patients describe as cough in the morning that is paroxysmal. Some patients have hoarseness in the morning by laying down, and the acid reflux going into the esophagus could paralyze the vocal cord, or could produce laryngitis or pharyngitis. Patients can also have a misdiagnosed asthma because they tend to have a fume, that fume going into their lungs and produce bronchospasm. And again, misdiagnosed as asthmatic patient adult onset, when it's not in reality asthma, it's just no more than irritation of the bronchioles by the acidic fume of the gastroesophageal reflux disease. So these patients tend to complain most of the time when they're laying flat in bed, mostly at night, and the symptoms tend to appear mostly in the morning, okay? And of course, they have recurrent aspiration. And that's exactly what happened to me. How do you diagnose this condition? Unfortunately, clinical is the most relevant way of diagnosing this disease, and diagnostic evaluation to be able to validate the symptoms. The only way that you can see that finding is by doing an endoscopy and seeing the actual lower esophageal sphincter that is not contracting properly. In addition to that, you could do manometry. Basically, you have to still go in by endoscopy and put a balloon to measure the pressure of the lower esophageal sphincter closing and opening. Okay? Another test that you could do, which is very simple and it's not invasive, but we don't do it often, is to basically monitor the pH of the esophagus. Normally it's alkaline. And if you see that there is an acidic pH at the level of the lower esophageal area, then that means that the patients have some degree of gastroesophageal reflux disease. In addition, what do we do barium swallow is not to diagnose lower esophageal sphincter. We do it for the complications that the acid can produce at the level of the lower esophageal area, which is no more than after severe periods of inflammation, scarring, and constriction, okay? So we can diagnose dysphagia produced by gastroesophageal reflux disease with barium swallow. Okay? So yes, many patients do have dysphagia, and therefore mostly to liquids, and they tend to aspire into the lungs as well due to the dysphagia. Okay? So how do you treat gastroesophageal reflux disease? Well, we do in clinical practice, for example, increase the motility of the transit time by giving Reglan, but that's not the best way to treat these patients. The best way to treat this patient is to decrease the risk factors, okay? Many patients tend to forget that they have gone through an episode of peptic ulcer disease and continue doing what they were doing before, drinking coffee and all the risk factors, and therefore the complication was already there, present, and they have a lot of occurrences. So how should you avoid, since you have already a damage of the lower esophageal sphincter, you're not gonna cure that until you go surgically, unfortunately, but how will you prevent the complications of gastroesophageal reflux disease? First, eat small amount of food several times a day instead of a big plate. Try to avoid to eat late hours at night. When you're going to sleep, try to sleep with the head elevated more than 45 degrees, okay? And of course, avoid all the risk factors. Now, why do we give proton pump inhibitors to these patients? And why do we go through this stepwise approach of antiacid, H2 blockers, and proton pump inhibitors? Basically to diminish the amount of acid that can go into the esophagus, therefore limiting the metaplasia at the right esophagus. So basically what we're doing is trying to limit the complications associated with gastroesophageal reflux disease, but it's proven that proton pump inhibitors, H2 blockers, or antacids doesn't do anything with the etiology of gastroesophageal reflux disease. Do you understand? Because it would not improve the tonicity of the muscle, okay? So what can we do surgically? Basically, what we can do is via laparoscopic, we could do fundoplication, basically is to increase the tone surgically to this sphincter, okay? To allow more constriction at the level of the esophagus. And if the patient does have already strictures due to scarring formation, due to the severe inflammatory process, you can also put a balloon and open up and dilate the esophagus, which of course is going to produce more reflux. Okay? Any questions so far? The only part that is a little complicated in GI is hepatitis. Okay? Due to the fact of the serology levels. All right? So what is hepatitis? You know that hepatitis is a viral, right? It's basically a family of herpes virus. And hepatitis, there are 3 different types, well actually 5 different types. You have hepatitis A, B, C, D, E, and even is coming G, okay? So you know that this is a given. You know that hepatitis A as well as hepatitis E, they have the same way of acquisition, so basically it's fecal-oral. So these are the patients that either they are manipulating food for others in restaurants, or when you go to a third world country, feces are, the water is contaminated with feces, in third world countries, and I can attest for Cuba, for example, the pipes are broken and there's a mixture of feces and water, and also the treatment of the waters is not the same as in developed countries. So patients tend to drink contaminated water that not only can produce parasites, but also can have all these infectious diseases such as hepatitis, okay? So it's basically person-to-person contact, all right? So washing hands is highly relevant for the transmission of hepatitis B. Hepatitis B as well as hepatitis C is mostly hematological transmission. Is sexually transmitted as well. Hepatitis C also is organ donation. So when the patients have tissue transplant or hemodialysis, they tend to have possible contamination of hepatitis B. So think about all the patients that can have blood-to-blood sharing. So for example, patients that are in drug abuse, that share needles, or if you, for example, receive a transfusion that is contaminated, which of course in a lot of countries that is rarely happening already. Dialysis patients, of course, sexual contact of any kind. But again, in hepatitis C, also think about tissue transplant. Yes.
You know that they're transplanting hepatitis C positive organs into non-hepatitis C patients, right?
What happened to C and anything else?
They're transplanting hepatitis C positive organs that are donated to non-hepatitis C patients. And as soon as they transplant them, they treat them with Harvoni and other.
Yeah, but are there?
Now, the major problem with that is that the highest between hepatitis B and hepatitis C, the one that has the highest complication of hepatocellular carcinoma and symptoms of the liver is hepatitis C. So the prognosis is poor compared to the others. We talked about hepatitis D and E, so there are fecal contamination as well. In addition to that, always think about patients with HIV as well that are immunocompromised, that they can acquire any of the types. And autoimmune conditions as well.
So recently, there was a pharmaceutical company, Delia. They released a new product for the hepatitis C. I think that the name is Fosbuvir. So I had the opportunity to work in the clinical trials, but no be part of the patient. I was part of the team.
Right.
I was doing research, and we just choose a few patients. So the thing is that sometimes you have to do like advertisement to try to get people for those trials. So people were dying to be in that trial because they get free completely of the hepatitis. And when they release the treatment, the treatment was so expensive that some barely can afford it. So it's $80,000 per month, the treatment. But you get rid of the hepatitis.
So yeah, there's a highly cure right now. But again, long term anyways, the prognostic factor is there for hepatitis C that is highly relevant to have hepatocellular carcinoma or cirrhosis. So I want you to be aware of the periods of hepatitis C when they convert from acute to chronic. So for example, patients have an incubation period, any disease process that goes through incubation period, remember that the patients do have already the acute disease, but they don't have any symptoms, okay? And I want you to understand that talking about the incubation period, during the incubation period, not only the patients have no symptoms, but the patients will start having the appearance of for example, hepatitis B, the appearance of the surface antigen at the end of the incubation period. So sometimes it's a disease process that is completely missed because even if you do serology on these patients, it's completely missed. There's no serology, there's no symptoms whatsoever, so you have no idea. Okay, the prodromal state itself, of course the patients already have signs and symptoms, but the symptoms are very vague until jaundice appears, okay? They can have weaknesses, they can have anorexia, they can have weight loss, until, of course, the symptoms of GI related starts to appear, but any patient that comes with abdominal pain, nausea, and vomiting, they're not gonna think about having hepatitis profile on the patient, right? So onto the patient, of course, tend to have more localized, because the abdominal pains tend to be more diffuse at the beginning until they have a localized right over quadrant pain associated with fever and jaundice, okay? And that's when the enteric phase appears. As you could see, it could last up to 10 days until the patients develop jaundice. So the first week period, the patients are either having a vague symptomatology, not specifically for hepatitis, or having completely be asymptomatic and no serology being positive, okay? So this is basically the icteric phase, that not all the patients go through this state. Sometimes there's a small percentage of up to 20% of patients only develop the icteric phase, and you can also miss the possible diagnosis. Now, the recovery phase, I want you to look at the recovery phase as two possibilities. Either the patient completely is cured from the disease, or the patients go through chronic phase. So recovery not only means successful treatment, diseases disappear from the system, and the patients develop proper antibodies, but the patients can go also into chronic phase, and that's where the complications come in, okay? Now, we're gonna start going into details in a second, but if you suspect that the patient, for example, now the patient went to Dominican Republic for 2 weeks of vacation, and the patient comes back a week after with nausea, vomiting, and abdominal pain, you have to think about the possibility of hepatitis, okay? And you have to rule it out, right? If the patient, for example, is a drug abuser, or the patient is an HIV patient, the patient is a dialysis patient, the patient has received transfusion recently, etc., you must suspect hepatitis in any patient with any risk factors that we already have mentioned, and diagnose accordingly, right? So what are you gonna do first? Of course, when a patient has abdominal pain, nausea, and vomiting, you're gonna do a KUB to any patient to rule out all the diseases that can produce the same symptoms. For example, coming from a third world country, not only can you do hepatitis A or E, but what else can the patient have? Well, for example, if you have a gastroenteritis, that can produce nausea and vomiting, right? Patients can have, again, parasites that can produce nausea and vomiting. So at least minimal, you would do a KUB. You might think also about possibility of bowel obstruction, so you could do a KUB, just to rule out possible differential diagnosis. So if you do a liver function test on a patient that has hepatitis, it will be elevated. Now, let me explain to you again. Liver function test has the aspirin transferase, okay, which is an AST, and has the ALT. Now, the AST is the most specific for liver, okay? Because the AST can come from prehepatic conditions and posthepatic conditions. And let me explain that. The liver, and this also applies for bilirubin, okay? The liver has an artery, which is the hepatic artery, which is a branch of the aorta, right? So anything that happens at the level of the heart, diminishing the supply of blood to the liver, can produce elevation of AST, okay? For example, if a patient has congestive heart failure, right-sided heart failure, okay, that produces congested liver, okay, that can increase the liver function test and can give you elevation of the AST, all right? If the patient has any type of hemolysis, I'm just giving you examples. If a patient has any type of hemolysis with sepsis, can produce hemolysis, okay? Or if the patient, for example, has a sickle cell disease, that there's a major hemolytic condition going on there, that at the time of the crisis, the amount of blood supply that goes to the liver is decreased. Or if the patient has any type of hypovolemic state, that the amount of blood supply that goes to the liver is decreased, anytime the liver goes into ischemia, the same as the kidney, anytime the liver goes through ischemia, the liver function test will become elevated. That is what we call in clinical practice shock liver, okay? So any disease process that decreases the amount of blood that goes to the liver temporarily will produce elevation of the liver function test. And this will be mostly elevated by AST. Okay? The same way bilirubins will be elevated. Because this is no more than a byproduct of the liver metabolism, right? And as well as the red blood cell metabolism. So if the patient has any type of hemolysis or any type of hypovolemic state or any type of cardiac condition that decreases the cardiac output, therefore the amount of blood that goes into the liver is decreased, into the hepatic artery is decreased, the patients will also have elevated bilirubin, okay? Now, which type of bilirubin will be elevated in this patient will be indirect bilirubin. Why? Look at the liver as the organ where all the enzymes get conjugated. Conjugation means that it's the medium of transforming macromolecules into small particles to be excreted by the kidney, okay? So, since the bilirubin is released by red blood cells, okay? And in addition, of course, you release bilirubin at the level of the gallbladder, but that will be another step, okay? The first pathway to have bilirubin release is by the breakdown of RBCs, right? So any disease process that can break down the RBCs will produce high levels of bilirubin. But that bilirubin has not had time yet to go into the liver to be conjugated into a small particle, right? So therefore, it's called unconjugated bilirubin or indirect bilirubin. Do you understand? So far what I'm trying to explain you here is that any disease process that happens before the liver, which is called prehepatic, which is no more than cardiovascular conditions, or any disease that decreases the amount of blood that goes into the hepatic artery by hypovolemia, or ischemia, or any disease process that produces high levels of breakdown of red blood cells by hemolysis, will produce liver function test elevated based on AST, and will produce also indirect or unconjugated hyperbilirubinemia. Okay? Now, once the patient has nothing to do with the heart, they have no heart failure, no valvulopathy that can affect the right side of the heart, they have no hemolysis, they have no hypovolemia, no ischemia whatsoever, okay? But they have a disease process at the level of the liver. In this case, hepatitis, or cirrhosis of the liver, or hepatocellular carcinoma, or what are the tubes or conducts that are connected into the liver? You have the pancreas, right? You have the gallbladder. And you have the duodenum. So if you have duodenitis, if you have cholecystitis, if you have pancreatitis, if you have hepatitis, if you have cirrhosis of the liver, if you have hepatocellular carcinoma, that can give you as well elevation of liver function test, but even though AST could be elevated because it's sensitive but it's non-specific for the liver, the one that is highly elevated will be ALT. Okay? But in addition to that, to confirm your diagnosis, you can do bilirubin, and even though the total bilirubin will be elevated, the one that is mostly elevated is direct conjugated. Okay? Understood? So alkaline phosphatase basically is no more than a byproduct of bone, kidney, and GI. So as you could imagine, if you have hepatitis, it will be elevated, but you don't know exactly where it's coming from. You can deduct based on the symptoms of the patient and all the diagnostic tests that you're doing, like liver function test. But if you have renal failure, you can have alkaline phosphatase elevated. If you have now a patient with rhabdomyolysis, you can have alkaline phosphatase elevated. If you have a patient with bone cancer or a patient that has leukemias or lymphomas or multiple myelomas, you can have alkaline phosphatase elevated. Do you understand? It's a sensitive factor of byproduct release when the patients are having diseases of the bone, kidney, and GI. So it's non-specific, okay? We talked about bilirubin already, and we're gonna talk about the serology, which you tend to have problems, okay? So let's start first with hepatitis A, which the easiest two are hepatitis A and hepatitis C, okay? So let's start with the easiest first, which nobody's gonna ask you. They're gonna let you know. Unfortunately, that's the easiest, so nobody's gonna ask you about that. So you remember pathophysiology that when the patients have an acute infectious process, the immune system releases IgM, right? And when the patients have recovery or go into a chronic state, the patient releases IgG. The immune system releases IgG. So, very easy. So basically what you have to look at is that, first of all, let me tell you how you can express antibodies in any serology, okay? So again, the patient goes through the incubation period, the patient starts having symptoms, and during the symptomatology phase, or at the end of the incubation period, the patient starts releasing his antibodies, okay? Antibodies are expressed as AB at the end of the serological test, or as an anti. So whenever you see AB or anti means antibody, okay? No antigen. Antigen is AG. Okay? So far so good? So that's the reason why in hepatitis A, so again, this is the patient that most likely went to a restaurant, right? Or loved to go outside to eat, or went to a third world country and comes back. And a week after the patient, because again, remember 7 to 10 days incubation period, the patient tends to start having abdominal pain, nausea, vomiting, and if nobody pays attention to that, or doesn't treat properly, or doesn't think about possible hepatitis, and since the patient already should have serological tests present, or the patient doesn't go to the hospital because many patients here had an indigestion, so let me just treat myself, and they delay treatment. Now the patient comes to you with the icteric phase, okay? So what do you expect to see on a patient that has hepatitis A acute? Remember, you always see the antibodies being present, okay? Unfortunately, in hepatitis A, we never see the antigen being released, okay? So you would see the anti-hepatitis A virus, IgM, very easy, right? And once the patient recovers, or the patient goes into complete recovery phase or chronic phase, which is really rare to have chronic phases in hepatitis A, D, or E, okay? But you want to know if the patient at any point had hepatitis A. Like many patients, for example, when I started with my husband, he told me that he had hepatitis. And I needed to know for sure which time he had. So we did a blood test, and we did serology for hepatitis A and B and C, of course, all of them. So what would you expect for him to have already after recovery? It would be the IgG anti-hepatitis A virus. You understand? So acute phase, anti-hepatitis A virus IgM, and chronic phase or recovery phase, or if you need to see for sure if the patient was vaccinated, because now we have hepatitis A vaccine, okay, or the patient has been exposed to hepatitis A in the past, you do anti-hepatitis A virus IgG. So far so good. Easy, really easy.
So vaccinated pre-exposure?
Yes.
Vaccinated.
Now let's go to C. Again, let's go to C because B is the one that's complicated, okay? Let's go to C. So, in hepatitis C, we have a major problem because we can never know because the patients can go into a chronic phase or recovery phase still having IgM present. And And because of that, because of the delay of appearance of IgG, we have been unable to detect exactly in which phase the patient is present for hepatitis C. Do you understand so far? So that's the reason why, to be able to know exactly in which phase the patient is present for hepatitis C, I have to do protein chain reaction, which is a higher level test. It's an immunofluorescence assay, okay? So, the reason is because the patients always will present with an anti-hepatitis C virus in acute and or chronic. And again, they can present an IgM in both phases because the appearance of IgG could be late in life. Therefore, I need to do an RNA, which is no more than a genetic test on the virus, okay? Which is immunofluorescence by protein chain reaction. So your answer will be protein chain reaction assay, to be able to know exactly in which stage the patient is present. So how will the patient manifest serological-wise in hepatitis C acute anti-hepatitis C virus? And in chronic anti-hepatitis C virus, there's no difference. So therefore, I have to do protein chain reaction, which is an immunofluorescent assay to be able to detect either or. Do you understand? Yes. No, well, that's an A. If I ask you as a general question, IgM is acute, IgG is chronic or recovery, right? Or that the patient has been exposed in the past to that particular hepatitis. Now, that applies for hepatitis A. Even though it does apply for hepatitis C, we cannot see IgG until later stages in life. So the patient can be 10 years and you still don't have hepatitis IgG, so how would I know? So therefore, I have to do a protein chain reaction, okay? Do you understand? Okay. Now the problem comes in with hepatitis B, and that's the one that you most commonly have tested, okay? It's too much, yes. Right, so let me talk first about what is hepatitis surface antigen. Imagine that this is a virus, okay? And every virus has a nucleus, RNA. Okay? Because remember, they are reversed, right? They have more RNA than DNA, right? So the problem is that when the hepatitis virus attacks the cell, okay, in the first 10 days of the disease process, okay, that the patient is in the incubation period, the patients have no serology. The immune system is only recognizing this antigen, this invader, this foreign virus coming in, and starts to produce antibodies. But the antibodies are never detected until the hepatitis surface antigen starts to fade off, okay? So, this is the surface of the cell, okay? So in the initial incubation period, at the end of the incubation period, close to 7 to 10 days, the cell, the immune system, produces an antigen which is called surface antigen, okay? Which is called hepatitis B surface antigen. So what I'm trying to tell you that the first that appear is the hepatitis surface antigen. And the last that disappears is the hepatitis surface antigen. Okay? But before this appearance, okay, of course, you develop antibodies against the hepatitis surface. Okay? Now, there's a period, just listen to me. I'm not going to ask you like that, what appears first, what appears second. No. I want you to understand why we have those different types. okay? So imagine that the hepatitis surface antigen appears first, right? And there's a period where the antibody is released, okay? During this period of conversion, the patients could be false negative serologically, okay? Why? Because the virus is trying to attack the nucleus, the RNA, which is called the core, okay? Now, for me to be able to differentiate in certain particular patients, because I don't know exactly what stage they are of the disease process, right? Unless I start counting exactly the days of the symptoms that appear, etc., and I'm doing a genetic test, I can do, because at this level of conversion from hepatitis surface antigen to antibodies against the surface antigen, since the core, the RNA, is getting attacked by the virus, the cell produces another antigen, which is called the core, okay? And of course, later on, once the antibodies against the surface are produced, at the same time, the antibodies against the core are produced. These are late, okay? You understand so far? Yeah. So far, just open your mind, right? Now, in addition to that, depending on your immune system, okay, the disease, or depending on the mutation of the virus, depending where you go, right? Because Cuba is highly mutated. All the viruses have different mutations. There's no treatment. They can do, the virus are dancing around. They have no idea what to do, right? So they pair and convert. So depending on where or what's happening in the virus cycle, you know, depending on how many amount of mutations the virus have gone through, or the highly virulence, listen to the word, the highly virulence of the virus, the disease process will be more severe or less, okay? So certain specific patients or certain specific viruses, because they're highly virulent and they're highly infected, they're highly mutated, they also release another antigen, which is called hepatitis B, E antigen. And then of course, after that, they're antibody. Okay? So, I'm just gonna point, before I say acute or chronic, I'm just gonna point to them, okay? So again, what is hepatitis surface antigen? The first that appears, right? Okay? But it could also be the last that disappears, so it could be also present in patients that have chronic conditions.
So last
And
disappears what?
And the patients that have been vaccinated. Just listen to me first and then we'll break this down. Okay? What is hepatitis B, little e antigen? Is only present in patients that have this type of virus, that have highly infectation, highly virulence, highly mutation. Not everybody, but it's very severe condition of the disease. And of course, it makes sense that the patient that's positive for hepatitis B, little e antigen, is the one that can have worse prognosis and more complications of hepatocellular carcinoma, liver cirrhosis, etc. Okay? Then, before I point to the antibodies, where's my core? Here. But here is not express the antigen, here is express the antibody, but you understand, I need you to understand that the core only appears in the transition period between the surface antigen and before the antibody of that surface is produced. So still means that the patient is in the acute phase of the disease. So let me summarize before you say anything. Before you say anything, let me summarize that. I want you to know that a patient is acute. So half the acute disease is highly infected, right? It's in the acute infection of the hepatitis B when they have the hepatitis B surface antigen present, because it's the first that appears, right? When the patients have hepatitis B little e antigen present, and when the patients have the antibody against the core, because the core only appears, even the antigen I'm presenting to you here, the core only appears in the intercession periods of conversion of the hepatitis surface and the conversion to the antibody. But before the patient releases antibody against the surface, not only the core antigen is present, but the antibody against the cores are also released. So in other words, hepatitis B surface antigen plus the core plus the E is acute infection. And if, of course, if you give me the IgM, it's even more. Right. Now, what would you not have? And I can open a quiz to practice this. What would you not have? Well, you would not have never ever the antibody against the surface, because that's the last of these appears. Sorry, the last that appears. So you would have the hepatitis surface antigen present, but you have no time yet to produce antibody against the surface. What about antibody against the E? Of course not. What about IgG?
No, it's not.
Okay.
I knew that.
Now let's analyze the chronic. Okay? The chronic, remember that hepatitis surface antigen is the first that appears and the last that disappears. That's the reason why the patients can still be in a chronic phase and have the hepatitis surface antigen present. Okay? The patient also has the antibody against the core, but what makes the difference? If the patient was highly infected before with the E, the patient has time to develop antibody against the E. And not only, if you don't have this, how would you differentiate? How would you differentiate acute versus chronic? You still have the surface antigen,
But because the anticorn.
you still have the antibody against the core, IgG, IgM. We have to do that. Do you understand? Okay. If the patient never developed the antigen against the E, of course it's not going to have the antibody against the E. Do you understand? But antibody against the E cannot be present in acute.
There's no antibody.
Negative for IgM. There's going to be negativity for IgM. Again, hepatitis surface antigen is the one that appears first and the last that disappears. So hepatitis surface antigen will be present in acute and chronic.
Yes. That's a good question. Yeah. That's, we should use that on test.
Okay? What else could be present in both? Well, in both, since the antigen for the core, which is the RNA, is present in the transitional conversion between hepatitis surface antigen and the antibody, their antibodies also released before the antibody against the surface appear. So it's still antibody against the core is present in acute and chronic. So what would be the difference between both IgM, IgG?
And possible antibody for the E.
If you have it at any place. Because if I get hepatitis B here, might not be the same aggression as in Cuba. Okay? Do you understand? All right. I'm going to practice that. Now, What is recovered? Remember, recovered could mean two things. Okay? Recover completely from the acute phase, or that the patient went to chronic. Okay? So, if you recover completely, you have no illnesses whatsoever. You never went into chronic phase. You just finished. You're cured. Okay? What will you have in difference to the chronic? Well, of course you're going to have antibody against the core. All of them have it, right? And in that case, it will be IgG still. All right? Now, what would you not have antibody against the surface what would you not have hepatitis B surface antigen? Because it disappeared. The first that appears, the last that disappears, but if you're recovered, you're gone. Everything's fine. So that's the reason why you do not have the surface antigen, but you do have the antibody against the surface. So again, what will be the difference between the recovered and the chronic? If you look here, in the chronic you have the hepatitis surface antigen, okay? You still have the antibody against the core IgG, that applies for recovered. So far so good? But in recover, you would not have hepatitis surface antigen, you will have the antibody against the surface.
Will be the last one, because it says by negative the
Just the
antigen
core.
and the HBS.
Okay. But negative antigen, but you would have the antibody against the surface. There's two cases.
Just many letters and they all mean something.
Now, vaccination.
I have a question. Why you don't have in the recovery phase the antibody against the surface?
You do. What you don't have is the hepatitis surface antigen. But what you do have is the antibody against the surface.
Which means it was,
Maybe it's misphrased.
does that mean that there was there's evidence that it was once there?
So like
Yes.
IgG.
You finished already, you recover completely,
But you know that they were exposed at some point.
you develop the antibody surface. Okay? Vaccination. What's the only thing that you can see once the patient gets vaccinated? The antibody against the surface. So that's exactly what you receive when the patient is recovered. The antibody against the surface. That's it. Okay? Because you already gave the antibody recombinant in laboratory, you're not giving the antigen. So that's the reason why the patient would never have the hepatitis surface antigen. The patient only would have the recombinant by laboratory, chemically already manipulated, the antibody against the surface.
I guess, what is the difference between the surface antigen and the surface?
The surface antigen is the virus itself,
Right.
okay?
And the
And the
surface-
antibodies against the surface is the immune system producing antibodies. So that means that your immune system is already activated and producing antibodies. Remember that the definition of an antigen is a foreign particle. It's something that doesn't belong to your system, right? It's the virus. The antibody is your adaptive immune system producing, or the plasma cells producing antibodies. The antibodies are produced after, not before. You need to have an aggression of the immune system for your immune system to recognize that as foreign and start producing antibodies.
Yeah, but
No, I know that.
when you give a vaccine, you're giving an antigen to the body to produce the.
No. Okay. You're right, but in certain vaccinations. If you give a live vaccination, like MMR, you're giving the live virus, so you're giving the antigen. And the body is in charge of producing the antibodies. Hepatitis B is already manipulated in the laboratory. You do not receive the antigen. You already received the antibody, passively. It's passive immunity. Okay? When you give immunoglobulins to the patient, that's Guillain-Barré, that's already manipulated in the laboratory, and you don't give the antigen, you give the antibodies. Passive immunity.
In the vaccination, will be negative, the antivirus percentage is going to appear.
Yes.
Because vaccination is.
You would never have any except the antibody against the surface. Okay? Let's practice this.
So, if you're giving the passive immunity,
That
oh, no, I'm
means that you're
fine.
giving additional
Let me log in
fuel for
myself.
the immune system to fight it off, right?
Yes. But when you're giving live viruses,
That's different.
when you're giving live viruses, you're telling the immune system, fight it yourself.
Right.
But when you're giving already recombinant antibodies in the laboratory, you're passively giving the immunity to the patient.
Extra
Correct.
fuel and protection.
Correct.
That's why you have to have boosters, right? If it's not as effective as if you were to give the active component of your immune system fighting off and develop.
Let's take 5 minutes, let me find some questions about it.